Good evening, everyone, and welcome back to the regulars to our Clinix Health Group webinars. We're so happy that you always join us whenever we invite you, and I think we are continuing as Clinix Health Group to host these webinars because of your participation. Your interest in continuous medical education is amazing. And I think that's what the whole objective of these webinars are for, to continuously develop our knowledge in medicine. Medicine is not static, as we know, dynamic, changes, new diseases come on, new methods of treating them, investigating them is come on. So knowledge is dynamic, and I think it's good that I think we always have a good number of participants. And I think I'm grateful to Clinix Health Group, the company that it's a private healthcare company that owns 8 hospitals and growing. But I think they have decided to host these webinars free of charge for practitioners. And I think for that, we are always grateful. We know that other webinars, there are webinars that charge a fee, but we will never charge a fee. All we need is your attention and your continuous support. We also invite speakers. So if any of you would like to share knowledge with your colleagues at any time over this platform, please let us know. And you can choose any topic of your choice. You just write to us on webinars@clinix.co.za. Webinars@clinix.co.za. I think you will be welcome. If you have colleagues who you think may be able to or willing to share their expertise with everyone, with their colleagues all over the country, please let us know so that we can approach them, and you can contact us on the same email address on any topic of your choice. If there's a topic that you'd like us to cover, and we get an expert to come and speak to us on it, please let us know as well if there are any particular topics of interest to yourselves. But today, I think we welcome you. But just as byproduct, I think we also offer CPD points. We've got a partnership with the Health Professions Council of South Africa. So we do offer CPD points for attendance and for speakers as well. But that's provided, of course, you did not get this Zoom link that you used to participate today secondhand. If you registered yourself on the link that we send out with our invitation on a weekly basis, then you would have put in your HPCSA registration number. And if once you've done that, you register successfully, you get a Zoom link, you will automatically receive CPD points via email from HPCSA themselves, Health Professions Council of South Africa. So you'll watch your emails within 2 to 3 weeks. On average, they will confirm that there has been CPD points have been credited to you. If you have a problem with CPD points not being credited after a month of attending any particular webinar on any week, please let us know. You can also write to us on webinars@clinix.co.za. During our talk today, our participants will be muted, so you won't be able to interrupt the speaker. But if you've got questions, or comments, you may put them in the chat box at any time. And our speaker today will deal with them at the end of will attend to them at the end of her talk. If you want to maybe put your question or your comment orally, you'll also be allowed to raise your electronic hand during the Q&A session, and you'll unmute yourself, and you'll be able to ask your question orally as well. But now let me go back to our speaker. Our speaker today is Professor Kgomotso Mathabe. Kgomotso Mathabe is, I think, Professor Mathabe is one of those who are well known in the field of urology in the country, especially because she was only the second Black woman in the country to qualify as a urologist. We know that urology is not popular in that there's not many who, for good reasons or for well-known reasons, because it's mainly males. It's assumed to be a male-only clinical discipline, but it's not. I'm sure Prof Mathabe will let you know that women also suffer, also patients of urology. You have urological issues as well. So it's not a males only illness, but for some reason there are much more male urologists in the country than female ones, and she was the second only to qualify in the country, but also the first one to qualify at Wits as a Black woman urologist. She qualified with a MED at Wits. She's also got an FCS in urology, but she's also got a PhD from University of Pretoria, and for that we congratulate her. She'll tell you about her topic in urology because it was also related to prostate and its association with the nervous system, interaction between prostate and the nervous system. We can see a process on the screen, Prof. People appreciate your qualifications and your expertise, but also you have a certificate in healthcare management as well. So you're not just academic, but you also, because you run the Department of Urology in the Steve Biko Academic Hospital, University of Pretoria Academic Complex. You are the head of the department clinically and also academically as well. You've got I think your certificate in management, you did it with Yale University through FDP, FPD, and for that I think we really congratulate you. You outside medicine, you also hold qualifications in education, gifted education, and you. I think one of your interests is mainly good health, education, skilled nation, and I think you say that a skilled nation can take care of its own problems and become a co-creator of solutions with government instead of depending on the government to do all the heavy lifting. I think education, skills development, and health services should be prioritized in the country, and health information and health promotion is your main interest, and that's why you do so many of these talks all over the country and internationally as well. And you believe in personal upskilling, personal development and upskilling, and I think that's why I think you volunteered to. When we asked you, you readily agreed to be our speaker tonight. I think over to you, Prof. I've said enough. Over to you. Thank you very much.
Thank you. Thank you, Dr. Kinoshi. And thank you to the Clinix group for the invitation, for the opportunity, for the platform to do this. So I certainly am a keen attendee of the CPD points. I learn a lot, and the learning outside of one's particular area, stuff that you're not dealing with on a regular basis, and of the recent topics that I've enjoyed the most. But they're all really just awesome. But Prof Devane Mashamba Thompson's work on point of care diagnosis, and I will be touching on that. And then the sports one was really interesting. I didn't think I'd be that fascinated. I'm not at all sporty, like in the least bit. I'm more interested in the sports fans than the actual sports. So really a wide array of presentations that keep us engaged. I mean, we definitely all keep coming back almost every week. So this is a brilliant platform and a brilliant service that you are offering to healthcare professionals. So thank you so much for the invitation. So I will talk a little bit. It'll bleed through into the presentation. It wasn't really the main focus, but I think it'll bleed through into the presentation as I go. My PhD was on the interaction of prostate cancer with the nervous system. And there's a few reasons that led to that. But I think the key one that I'd like to just mention here, because I am big on African solutions for African problems. And prostate cancer is one such area where we really do need to look at our own particular solutions. Um, and I was greatly bothered. I was greatly bothered by seeing patients come into hospital with spinal cord compression. Now, spinal cord compression would be from a growing mass from the prostate that has reached the spine and is compressing on the spinal cord, leading to paralysis, leading to urinary incontinence, leading to fecal incontinence. And this is how these patients will conclude their lives, right? So this is a man who has lived, who has done all sorts of things with his life, and right at the end of his life, he's unable to walk, he's unable to care for himself, he's unable to control his bowels and his bladder. And that for me was really bothersome. And we see this not infrequently. And also because, these are things that well-resourced environments, the global north, doesn't see that often, right? If you've got an active screening process, you're going to catch disease early, you're going to catch prostate cancer early. Um, and there's two groups of our patients who present with spinal cord compression. Some of them, they are known with prostate cancer, and we've been looking after them for the prostate cancer for some time, and then they come in with spinal cord compression. But some of them are not even diagnosed, so that the first time we are diagnosing their prostate cancer is when they come into hospital and are unable to walk. And that for me was the source of great distress. And that is what then drove my interest in actually doing the PhD on this particular subject. With that said, then I will jump into the presentation. It's going to be more of philosophical and asking, the audience to sort of ponder and think on things. But I wanted to look at the continuum of prostate cancer development and progression, and what are our opportunities to intervene. Let's see, my slides are now not moving. Okay, there we go. Okay, so the overview is who am I talking to? We're going to look at the prostate cancer landscape and the narrative globally and in South Africa. We're going to look at the progression of prostate cancer, the continuum from somebody who's completely disease-free to somebody who's got, spinal cord compression and other metastatic disease. We're certainly going to talk about the need for more continental and national research. What does intervention look like at the different phases of this continuum? And what about point of care? And then what after the diagnosis? So that is just the overview then. So who am I talking to? On a personal note, I'm talking to the men in the room. I'm talking to the Black men in the room. But I'm also talking to the women in the room who have husbands and sons and fathers and uncles and nephews friends who are male. So this is pretty much everybody's concern, right? This is not just a particular category of people. This is literally all of us have reason to be concerned here. On a professional note, who am I trying to reach out to? Okay, I think there are people who can be partners on this journey, collaborators. We definitely need to be collaborating on our efforts to address this issue. I'm talking to the big picture people, policymakers, health economists, people who hold the purse strings, and people at grassroots who are the implementers and who are caring for patients with prostate cancer, because it takes a village. One of the other things that distresses me in this space of prostate cancer is the vocabulary around Black men. So if you read international texts, it speaks about Black men having more aggressive disease. I personally wonder, is it more aggressive disease or is it more advanced disease? Because there is a difference. If somebody has got disease over a long period of time, anybody who has the disease over a long period of time, it's going to become more aggressive. It becomes more disorganized. The histology becomes more disorganized over time. So if you're catching somebody in month 1 versus somebody in month, 37, so can we truly say that somebody that we are seeing for the first time in month 7 has actually naturally got more aggressive disease, or is it just that it's more advanced disease when we're seeing them? So access is a big part of how we define what is going on here. And so it is said that Black men have more aggressive disease, they have a higher incidence, earlier onset, poor compliance with treatment, higher mortality. And words are important. When I speak to the undergraduate students, I often say to them, we really need to watch our words. And sometimes we're very judgmental, and without even intending to. Some of the things we don't actually mean to be judgmental. But by the time we're calling a woman hysterical just because she's got a uterus, right, that is quite judgmental. By the time we say, so when in a ward round, a student presents a patient to me and they say the patient presented late. Now, patients will first go to their local clinic, and there they might or might not be attended to. Oh, Baba, it's okay, it's age, it's because you're getting old. And then they might, come back after a couple of weeks, and then they're referred to their local clinic, their local hospital, where they might or might not get a PSA, where they might or might not get a digital rectal examination. And eventually, when a PSA is done and the suspicion of prostate cancer comes to the fore, they then will be referred to a center that can do a biopsy. That is something, I think today, if we get a phone call today looking for an appointment for a biopsy, we've mitigated that because we've recently had a prostate biopsy drive. But outside of that, it is literally more than 6 or 7 months. So if the person has been trying to get to where they can be referred for 3 or 4 months, and then by the time they are referred, we are giving them a date of another 6, 7, 8 months. It's not that they're presenting late. We might be seeing them late in the tertiary center where they need to be seen, but this is not their first attempt to seek help. So when we say that a patient is presenting late, that's already judgmental, right? That's just such a simple sentence that we say, but we are already being judgmental towards a patient. So these words for me are quite important in how we approach what we say about Black men and prostate cancer. The cancer landscape in terms of globally, so the US versus the UK, the islands and the Caribbean. So it is said that, the highest incidence of prostate cancer is in Black men. And if you look at the US data, the US data shows that indeed Black men present with aggressive, I call it advanced disease. But that patients who come from West Africa and from the Caribbean seem to have a higher incidence. If you look across the world, certain areas have lower incidences of prostate cancer, like the Far East. And is it a dietary thing? But certainly the Caribbean has got a high rate. But if you look at UK data, where they have universal access to care, you find that the incidence of prostate cancer between white and Black patients is very similar. So again, it speaks to, is it actually about access to care rather than race, right? Race, genetics definitely play a role, and there's a lot of studies being done, a lot of research going on in that area, but one must balance these perspectives. Right. In Africa, we've got our own particular set of challenges, and I'll touch on the South Africa specific challenges. So again, if you look at the global can estimates, that doesn't come out every year. So the last global cancer estimates was then in 2022. And it does speak to a rising incidence of prostate cancer, but is it actually that the incidence is rising, or is it that we are testing more for it? And so when we speak about prostate cancer screening, that's quite an interesting and important one. So if we do, wide screening, which has health, economics, and budgetary implications, but if we screen widely, we are going to catch more disease, so the incidence will be higher. But when we screen widely and catch more disease, we run the risk then of overtreatment, because we might then catch disease that was never going to be clinically significant. And within the oncology circles, we say that more men die with prostate cancer than because of it. So prostate cancer is not a death sentence, but determining in which patients is it, does it have a more lethal potential? That's where the magic lies. So according to Globocan, these are the stats. The cases about 1.5 million in the world per year. I don't believe that is true. It ranks fourth in terms of cancers amongst males. The mortality is eighth, with just about 400,000 deaths per year. And I don't think that tells the full story at all. In terms of the landscape in South Africa, the National Cancer Registry is where we capture our cancers that occur across all the age groups and the genders. But on that National Cancer Registry, what are we actually counting? What are we reporting? And how is this influencing decisions and policy? So our cancer registry is still a biopsy-based, pathology-based cancer registry. And we're going to drill down a little bit into that. And at some point, cancer was not a reportable disease. And so at that point, the private sector, so in 2011, then this changed. But up until that point, there had been concerns from the private sector about patient confidentiality and that sort of thing. So they were not reporting their data. Our national data did not actually account for what was happening in the private sector. There is a paper, I don't know, this slide then speaks to a paper that was done in 2015, where they looked at the impact of the private sector data not being reported, and that actually accounted for only 4% of the total incidence. So we'll talk about that. Since 2017, in Ekurhuleni, they now have a population-based cancer registry. And that is an interesting aspect. So population-based versus pathology-based are interesting, because pathology-based has a very specific implication, which we will get to shortly. But population-based registries sound like they're better, but I think that also is something that needs to be refined, because it's then looking at clinically, radiologically, and I'm curious about the choice of word here, because this is from the Cancer Registry website. Then it says, and pathologically diagnosed. So is it all three that must be present, or is it if any one of those is present, then we can still call it a cancer? Because a cancer that happens, in a far-flung rural area where a prostate cancer, where on digital rectal examination, it feels abnormal, the patient has got constitutional symptoms, they might have had access to a PSA, and the PSA might be raised. Very basic skeletal x-rays might show mets. Such a patient who does not have access to a urologist to do a biopsy and to get a biopsy and get pathology results, that we don't count that person. That cancer is not counted. It walks like a duck, looks like a duck, quacks like a duck, but because we don't have histology, it is not counted. So for sure, our numbers are not reflective of what is going on in the country, right? So, like I said, on this paper from 2015, the authors looked at the impact of the non-reporting at that time, which has changed, of the private sector and feeding in their results to the National Cancer Registry. And it was just a 4% portion of the population that hadn't been captured, meaning that 96% of patients that were seen with prostate cancer were people who are served by the state, right? So the value of cancer data definitely is the cornerstone of cancer control. We need to know what is happening, right? We cannot predict or determine or give direction to where we want to go if we don't even know where we are. But there are lies, there are damned lies, and then there's statistics, right? People can really massage and manipulate numbers. So we need integrity in the space. And so these are both quotes by Mark Twain, where he said there are lies, damned lies, and then statistics. And he says facts are stubborn, but statistics are more pliable. So people can certainly fiddle around with the numbers and make them tell a certain story. And that's why we need more people in the room, right? More people who are interpreting, more people who know what is happening and giving direction to what next. Because if garbage in, garbage out. If we don't have the right information going in, we are going to make very wrong assumptions about how we should move forward. So the top invasive cancers reported in South Africa, the top bit there is in males. So number one is prostate cancer, and in females, then breast is number one. And we know that there's a lot more awareness happening about breast cancer. Women know that we should examine our breasts regularly, mammograms, all of that. There isn't the same kind of attention to male health, right? There isn't the same degree of demystification, giving people the language, giving people the space, giving people the knowledge. Some people don't even know where their prostate is, right? And so these are things that we need to address. And so male health really is very under-resourced. And this is a problem. This is a problem. And it's not just a male problem, right? When we ignore one sector of society, the entire society actually suffers. A caveat to this is that the number of prostate cancer being the highest is excluding skin cancer. So if you look at skin cancer, then that is actually number one because one typically white male, right, Caucasian male, can have multiple lesions that are malignant, and therefore one person can add multiple entries to the registry. And so just accounting for that, then the skin cancers are not regarded in these calculations. I don't know how well that is going to project, but really it's just to paint a picture. So you don't need to know the specifics of everything. But so this is the 2022 National Cancer Registry data. And this is now Black men. And if you look at the bit with a circle on the top line, that's the total number of Black men who were diagnosed with prostate cancer in that year. And it's just over 5,000, all right? Which, we know those that sit in clinic all day in oncology clinic know that if you were to look at this nationally, there's no ways there's only 5,000 men with prostate cancer in the country. And so if our data is garbage, then our output is going to be garbage, because if we are basing our planning for how many urologists and oncologists and nurses we need, and if we're dealing with such low numbers, then we're not going to be very impressed about the need for providing the training. So this is a problem. But beyond that, on the next slide, it is then the number of white males in the same time period in South Africa who are diagnosed with prostate cancer, and you'll see that it is just under 7,000. So in a country which is, 85% Black, with supposedly prostate cancer being more frequent in Black males, more aggressive, more everything that is negative, we now sit with numbers that indicate that there were more white males who had prostate cancer during this time period. And so I hope you're beginning to think about what this data might actually be telling us. And I hope that as you're pondering on that, you recognize that it's not telling us the incidence, right? There is no ways that there are more white males who have prostate cancer than black men with the population that we have. And we'll go into that a bit more. So what are the numbers of men of the different races captured in the registry actually telling us? And it is not incidence, right? This speaks to access, and not just access within the private sector. I mean, we've now got Black people who are of a different social and economic class who can access private healthcare. Excuse me. So it's not just that. But what it is that, like I said, the patient who sits in a far-flung rural area, who does not have access to a urologist, because 99% of prostate biopsies are done by urologists. And so if you are nowhere near an academic tertiary center, because there are no urologists in far-flung rural areas, certainly not in state hospitals, and therefore if you do not have somebody who can do these biopsies in those areas. So all that these numbers are telling us are the men who were able to get a biopsy and had a pathological specimen that could then be captured on the registry, not who clinically has got prostate cancer. And that's a problem, right? Our data is then not a true reflection. So there are a few papers done in South Africa. We definitely need to be doing more research. But in this one, they looked at the cancer registry in terms of incidence and mortality rates of prostate cancer. And there was low rates, excuse me. The mortality rate was high and increasing, and the incidence rate was higher and increasing due to, widespread availability of PSA. But the narrative of advanced cancer, late presentation, bleeds through most of the papers that are written in South Africa, right? And in this one as well, where just the profile of Black men who presented with prostate cancer in the Free State was reviewed, still spoke of, advanced disease at presentation. So what is the continuum of prostate cancer progression? So we go from somebody who does not have prostate cancer at all, and over a period of time, the latency period, by the way, is about 10 years. So it takes about 10 years from when malignant changes begin to occur in the prostate to when they are then detectable by our current means. So we have a long period during which we could actually intervene and bring about a change to the outcome. So you have that oncogenesis period where malignant change is happening at a histological level, after which then the patient has got localized prostate cancer, but they will be asymptomatic at this point. So prostate cancer, for the most part, is asymptomatic until it is metastatic. And so we cannot look to symptoms to tell us that somebody has got prostate cancer, right? By the time the symptoms are telling us that, we've actually missed the boat. After the period where the cancer is just localized to the prostate, it may then spread to the rest of the body. And the routes of metastases historically are transcelomic, hematogenous, lymphogenous, and contiguous. That's what we were all taught in, undergraduate. And so my research then proposes an additional mechanism of prostate cancer. Okay, I can only speak to prostate cancer because that's what I studied. But seriously, I think this is something that is going to be found to apply to cancers in general. I think the landscape of cancer neurobiology is going to change once we fully acknowledge and recognize the role that nerves have in what goes on in the body. So there are the historically recognized mechanisms of cancer spread, and through my work, then I suggest that there is a fifth route. And one of the things in the PhD, in the research that I did, was I did cadaveric dissections, and we had a cadaver who was 40 years old at death, a black cadaver, and he had died of I think it was like gastroenteritis or something, which was already curious, right? Which adult male dies of a gastroenteritis? But obviously, you don't have all of that preceding clinical information. But it was an adult male who was recorded as having died from a gastroenteritis, and then had so we did the dissection, looking at his prostate, looking at the nerves in and around the prostate, and he was found to have prostate cancer. I mean, he's 40 years old, all right? He was found to already have histological evidence of prostate cancer, which is worrying enough, and that whole talk of the latency period. But he had cancer that had spread into the nerves already. So he had evidence of perineural invasion at the age of 40. That is one of the signs for us of advanced disease, right? And at 40, he already had that. So how much that had to do with his eventual demise, and how much was this gastroenteritis, one becomes curious. But that there was evidence found in one so young. The elements of the continuum we'll touch on in a little bit more detail. But certainly perineural invasion is something that we recognize. Pathology reports have always reported on perineural invasion if it was present. But the distance from the prostate to the spinal cord, and I've said about the patients who present with spinal cord compression, that distance is a mere 10 centimeters, right? It's not very much. And so there's lots of room for stuff to happen in those nerves that go from the prostate towards the spinal cord. And so the idea of propagation of prostate cancer along those nerves, from the small tiny fibers within the prostate, and progression and propagation to the bigger nerves that surround the prostate, to the named nerves, the iliohypogastric, prostatic plexus, as they travel towards the spinal cord. So, and this was shown on MRI. We are able to show evidence of prostate cancer traveling along those nerves. So it's an interesting route of work and opportunities for further research there. I will not talk about the tumor microenvironment. That is something I found highly, highly interesting. And I think there's lots of information to be unlocked in that space. But in my study, we found that patients with prostate cancer had a 300% higher levels of pro-neuropeptide Y. And I think this provides an opportunity for possible intervention in terms of drug discovery. So we need more continental and national research. We certainly need the clinician scientists. Zora Neale Hurston described research as formalized curiosity. I really like that. She said it is poking and prying with a purpose, right? And most of what we see on a daily basis in our clinics and OPDs and rooms really, is worthy of further prying and poking. And then I love this, as I was getting ready, as I was working on my thesis, that somebody sent me that, and saying that thesis is to define yourself. So I think this is important for us as Africans to define ourselves and to define our circumstances. So if nobody else is seeing spinal cord compression from prostate cancer, we see it. Right? So we don't need to wait for permission for somebody to say to us, oh, okay, maybe this might be worthy of study. We don't need somebody to come from Europe and look at our stuff and find it so fascinating and interesting and give us direction on that. We can look for ourselves on a daily basis. What is it that we're experiencing? What is happening in our communities? And our communities is not just what we're seeing in the hospital, right? There are things that we are seeing when we go home to the village on the weekend, right? When we are in the township, when we see things, and we should absolutely be curious about those things and want to study ourselves and to want to create the narrative around ourselves, right? So for people to be telling us how terrible we are at compliance, how terrible our disease is, and how, genetics are a problem, let us be a part of figuring that out, right? So we do indeed, as a people, need to begin to define ourselves. And I think one of the biggest gaps in terms of national research is the coordination. I think a lot of people are doing great work in their little pockets, And we really still need to do something that brings us all together and coordinates our actions, because some of us might actually be, repeating something at somebody, whatever, 200 kilometers away or 100 kilometers away that they might be doing. So I think we get more bang for our buck if we had better coordination and we could move things forward instead of maybe reinventing the wheel. That I think sometimes we are doing that. And I think the MRC is trying to bring that into being, that there begins to be a little bit more coordination and collaboration. So yes, each of us individually will chase a particular area of interest, but there needs to be a big brother looking out over the situation. And I know that the public health specialists are really good at wanting to direct all of us. Surgeons think that, I've heard surgeons say that, we are the tip of the spear. And somebody very cheeky said, but well, who's holding that spear? All right, so public health friends can just guide and direct, because when I'm sitting in front of a patient, that's my only interest, right? I don't care how many thousands outside have got that condition or what is happening. And so we need the balance of the public health outlook to guide what we're doing with our resources, including the doctors. The clinicians are actually a resource and they need to be given direction. So sure, we can give our inputs, but there needs to be coordination and collaboration in how to best use the resources available, their funds, their people resources, their capital, the equipment, all of that. There needs to be just better coordination and collaboration. So what, in terms of national research, then the other areas, so I think this slide really speaks to okay, so I'm speaking to UP, where I am, and Steve Beaker, our patients here. But really, so we are doing work. There's, NUMERI, there's a Pan-African Cancer Research Institute, there's the Center for the Development and Implementation of Point of Care Diagnostics. So there's definitely work happening here. But we need to be more collaborative. And I think those three particular centers and institutions are doing a better job of this. The coordination of clinicians and basic scientists. I think that's important. The scientists bring a particular perspective to things that the clinicians don't necessarily have, and the clinicians bring a perspective that the scientists don't have. And so I think that collaboration is where the magic lies as well, right? Not each of us just chasing our own little corner. So what does intervention look like at the various phases of this continuum? So at the latency period and the period of oncogenesis, the space of cancer development, nerves are now being discovered to be quite important in cancer development. So I was looking only at the role of nerves in propagating cancer, so cancer that has already happened, and how they transport it as a conduit, literally from one spot to another. And this would be contiguous. But there is increasing research that is looking at the probable, so it's no longer even possible, the probable role of nerves in the initiation of malignant change. And so who should be screened for prostate cancer? If you look at the international guidelines, they speak about people of African ancestry being at a higher risk. Well, that's our entire country, right? If we are screening based on your African ancestry, then that's pretty much all of us. And so that's why we need to get together in rooms and look at our own situation and how do we best deploy the resources that we have. Because if we are looking at people of African ancestry, then we're not actually really screening to, figure out who might have it. Everybody has got that risk. And so we need to be having conversations about how to deploy what resources we have and determining our own guidelines. If you've got a family history, but only 1 in 10 cases of prostate cancer are familial, right? So family history is not as strong. I mean, what I'm saying with that sentence is that 90% of people with prostate cancer, it's a random event. It's not a genetically based family history event. But obviously, if you do have a family history, especially of people developing prostate cancer young, and by young we mean less than 50, right? Or if you've got 3 consecutive generations who have had prostate cancer, you're somebody we need to start screening earlier and just have a keener eye on your particular life journey. What we do is, because we don't have a national screening program, and the public health people will tell us whether we can actually afford it, and I think that we can't. I'm not sure that even if we could, whether we should. So, more of that pondering and the ethics of things. But we do screen opportunistically, right? So if we do get a man who comes in with any other thing, who is of an appropriate age, while we have them in hospital, this is, a good chance. Men generally don't end up in hospital. And so when we do, so that's how we are screening, not as a national screening program rolled out. And then diagnosis and follow-up in terms of localized and asymptomatic prostate cancer. That's really where we want to catch it, because if we catch it while it's localized, what we're saying is that the cancer is only in the prostate, in which case, if we remove the prostate, we have solved the problem, right? So certainly that is an ideal situation. Once it has metastasized, we then need to be looking, our interventions are, after the metastatic workup, how do we follow up the patients and how do we relieve their symptoms? Because at this point, we are not able to cure what they have, but we certainly can make them, pain-free and that sort of thing. So that's important. And then drug development, I think in the metastatic space, drug development, the role of the nerves in the dissemination of cancer. So beyond the historical 4 mechanisms, the role of the nerves in prostate cancer dissemination, I think, gives us an opportunity for possible intervention. A national screening program, can we afford it? Can we afford not to have it? I think that's a point of interesting debate. If we are screening routinely everybody, let's see if that's the next slide. Okay. Ooh, okay, still a few slides to go, but yes. So maybe we'll get onto this national screening program when I get onto one of the latest slides, because I think it speaks quite well to that. What about point of care diagnostics? So I attended the inaugural lecture of the the Center for Point of Care Diagnostics at UP a couple of days ago, and this is a big area. They're gonna bring out some phenomenal work, very interesting work that they are doing, and I just wondered if there was an opportunity for us as urology to collaborate with them in terms of getting point of care diagnostics for prostate cancer. And I was initially thinking about, far-flung rural areas. I like the idea of the pillow pepper train and how they are delivering care to places that otherwise wouldn't access care. But in this inaugural seminar, they were talking about point of care diagnostics in the primary setting, in the secondary hospital setting, and even right here in tertiary centers, right? If we can make the diagnosis right there and then, but they're making a very big case from the pathologist side about the quality control element of point of care diagnostics, right? So we want to be able to have a test that we can depend on. If it comes out and says, yes, we've got prostate cancer, I need to know that I truly do have prostate cancer. So the quality control and the regulatory framework that still needs to come into the space to support that, I think, are very interesting areas that are going to be opening up, and conversations that are going to be opening up. And I think as a urologist, I would like to be a part of that because I do have men that are within our catchment area but are far from care. So the options for point of care diagnostics, there's a lot of work happening around liquid biopsies, the possibility of doing liquid biopsies. And so saliva, blood, urine, could we be testing those? And that's leaning on the omics platform, so genomics, transcriptomics, circulating tumor cells. Could we be, drawing a blood test, not to check the enzyme that is PSA, but to check for the presence of circulating tumor cells, right? So I find that a very interesting avenue as we go forward. And some work has been done in the Cape, where they were looking at they did proteomics of urine and looking at what they might find that might allow us to do pretty much a point of care test. If we did a urine sample and did that test, would we be able to determine if there's cancer already, right? And we might be then able to catch it a lot sooner than what we would be able to find on a digital rectal examination. And that's just more of that work in terms of proteomics-based biomarkers for prostate cancer. So I'm going to stop on this slide for a minute, and I think there's maybe another one or two after this, but what then after the diagnosis? So let's say we develop these awesome point of care diagnostics. We send, one of my registrars a couple of years from now goes off on the pill pepper train or whatever the equivalent will be at that point, goes around the country, testing people, finding the patients with prostate cancer, hopefully early prostate cancer because we're screening. And then what? And so this for me is a point of very real concern. And this is where, I need all the other friends in the room to become a part of the conversation as to what happens next, because I have this fear. I literally have, palpitations at the thought of we're going to go out there and do mass screening. And then we're going to catch a whole bunch of people with prostate cancer. And especially if we catch it early, then what do we do with it? What do we do with them? The pipeline of urologists for this country is shocking. The numbers, we have 0.56 per 100,000. We don't even have a whole urologist. We don't have one whole entire urologist to cover 100,000 of the population, right? Global averages are at about 9 per 100,000. I think in the US, they've got something like 1 for 47,000 people. We're not even getting to 100,000. So I have this fear of, these awesome basic scientists are going to develop all these fabulous point of care diagnostics and liquid biopsies, and we're going to be able to diagnose prostate cancer literally on the spot. And then what am I supposed to do? Because if you come to Steve Beak on a Thursday when we have our oncology clinic, it is like so many people here. And so we do not have the capacity. We are only 4 consultants at Steve Beaker. We have nobody at Galafong at the moment. We have nobody. Okay, we've got a sessional urologist at Tembisa, and we do not have anybody at Mamelodi. So if I'm literally relying on 4 full-time specialists in this cluster, and then we go screening and looking for people, what are we supposed to do with them? And so this for me is reminiscent. So I was coming up through the ranks at the time when HIV was like a real thing. And I used to be very distressed as an intern when the consultants would ask me to then do an HIV test on the patient, right? So I counsel them about this disease. I do whatever needs to be done to confirm it. And then it comes back as positive. And then what? Right? And so I'm sort of having those same anxieties about this, so that we need to absolutely be planning for the care and management of these patients that we are going to diagnose when we go looking for this disease. Because we go looking for it, we're going to find it. And it is not fair for us to say to somebody, yeah, you've got this disease, especially if we're able to risk stratify and we're able to determine which patients have actually got potentially lethal disease, right? Clinically significant and potentially lethal disease. And then we're like, yeah, okay, sorry, right? So we need to manage this part of prostate cancer care very, very carefully. So there's our 0.56, half a urologist for 100,000 male adult males in the country, right? Not enough. And that is it. Thank you so much for your attention. And that is it, Dr. Kinoshi. Thank you.
Thank you very much, Prof, for new education. I mean, even at our age, I see a comment from Prof. Du Plessis also says, thank you very much for teaching me. What does he say? I'll read from what he said, how he puts it. And I think it says a lot. I think he's spoken for almost all of us. He says, I did not realize that. He says, thanks for teaching me new things at this day, and I think this was amazing. I think we always have thought that we have heard enough about prostate cancer, but I'm sure people can realize, as we can see a process on the in the hearts on the screen, that people are quite thankful that they attended this lecture. I think those who haven't missed a lot, I leave the rest to my colleague at the end to do the thinking. But I'm impressed with the lecture that I received personally today. Thank you, Prof. And there are a few questions in the chat box, and if those who would like to put their questions or comments orally can raise their hands, and I can see Tolakele, there are already some hands. I'll come to them. I just want to take one or two on the screen first, and then we'll after taking two, we'll go to the hands. But please keep them up until we come to you. Prof, just the first one, I think it's Dr. Khan. Dr. Moy Khan says, does circumcision influence prostate pathology? He's got two questions. Maybe let me put both of them. I don't know whether you can see your chat box as well, Prof.
No, I haven't opened, but let me open it.
That's right. Does circumcision influence prostate pathology? But his second question is, beyond PSA, right? PSA and digital rectal examination, I suppose he didn't put it like that. Beyond PSA and digital examination, please advise the need for free PSA testing. Maybe let me stop there for now.
Okay.
Yeah.
Thanks, Dr. Kgomotso.
In other words, circumcision and prostate pathology, is there any association?
Yeah. So no association with circumcision. There are benefits to circumcision in certain pathologies, which need to be weighed up very carefully against the risks, the increased risk behavior that happens after people have had a circumcision. So it is not, get out of jail free card if you have a circumcision. So one must still continue to practice safe sex and to practice healthy behaviors, but no direct linkage to prostate pathology. And then in terms of the free PSA, so certainly PSA is not uh, an ideal tool for testing for prostate cancer. It's what we have. It's what we've had for a long time. It made a huge difference when it came about in the 80s when it was approved by the FDA. So it's an awesome thing, but it definitely has got deficiencies. And so all sorts of efforts are going into trying to improve it. So either to find an alternative to PSA, and that's where I think the omics research, multi-omics research is probably going to make the biggest difference, excuse me, but also means to try and improve then on PSA. What can we do? So we speak about PSA derivatives. What can we do with this PSA that we have that is available to try and make it more sensitive, to try and make it tell us more, right? Because it tells us that there's something going on in the prostate. It does not tell us that there is cancer in the prostate. So it tells us about the organ, it's organ specific, but it's not disease specific. And so we look at pre-PSA, we look at the ratio of the PSA to the size of the prostate, because that's quite an important one. So there's all sorts of means to just try and make PSA deliver more, to try and extract more value from PSA. But maybe additional to that, I can say, yes, there's the PSA. Yes, there's the digital rectal examination, but we also now can look at the prostate, visualize it using MRI. And MRI has really been quite a game changer. It is unfortunately an expensive investigation, but it is quite a game changer in that with MRI, we get to see the entire prostate. All right, so already that's big because we might miss a lesion if it's sitting in an area that is not accessible to us by biopsies. And anterior prostatic cancers, most of them are posterior, but you might have an anterior lesion and you can't access it through the normal route. So you would have somebody who's got active disease and you are unable to confirm it on biopsy. So with an MRI, it images the entire prostate. And they use a system called the PIRADS. And the PIRADS then can tell us whether this, do we have multiple lesions or just one lesion? And if we have multiple lesions, are they clinically significant? So we're able to say, oh, no, this one, this patient is going to die with his prostate cancer, not because of it. This is hardly going to be a thing for this particular patient. Or then to say, no, this is a clinically significant cancer that needs attention. So certainly MRI has come into its own. And there's actually new work now with nuclear medicine. There's a paper, it's maybe like 3 or 4 months. This is literally very, very new work that is showing that PSMA PET CT may well also be able to diagnose prostate cancer, because at the moment we're diagnosing prostate cancer on biopsy. So MRI has come into its own, where it can, just on the basis of the MRI features, you can confidently say this is a cancer. And now nuclear medicine studies also come into the space where we can, just by looking at that without having done a biopsy, confirm. So there's definitely development in this space.
Thank you very much. I think you've said a lot about PSA, because most of us men think that if you've done your annual PSA, then you're and the amount is within normal range, then you're safe. But I think you've said a lot now. I think that we need to do more, or ask our urologists or doctors to ask for more on the PSA. Let's take, I think I don't know whether it's Dr. Princess Moremong. You can unmute yourself and put your question orally before we go to the chat box again. Tolakali, can you assist? I think it's Dr. Moremong. You can unmute yourself and ask your question or comment, please. All right, we'll come back to you. I think she's having a problem unmuting. Let's go to Dr. Motlante's question. Dr. Makale Motlante is making an interesting comment. He says, you spoke about the cadaver, the 40-year-old cadaver, Prof. She says the lifetime risk of a 50-year-old for latent CA prostate detected an incident incidental finding at autopsy is not related to the cause of death, is 40% for clinical apparent CA. For clinical apparent CA is 9.5%. Can this lead to overdiagnosis of CA prostate in this age group? Because he says the 40-year-old cadaver is of a case of interest.
Yes, so absolutely, right. And that is our dilemma as urologists and oncologists, is trying to find this balance. But there are more and more tools. Like I'm saying, the MRI is actually brilliant in that, but it's not accessible to everybody, and it is an expensive tool. Because yes, somebody can have latent, clinically insignificant prostate cancer. But if we're testing everybody, if we're screening everybody, we are going to pick those up. And there were studies done in Europe and in America, where they were looking at both sides of the Atlantic and looking at routine screening versus opportunistic screening. And they did find that we overdiagnosed prostate cancer with that, and overdiagnosed clinically insignificant prostate cancer. And my concern about, I need the clinicians, I need the pipeline of people who are going to treat these patients once diagnosed. And so I need people who can determine who is clinically significant. And once that is done, the one who's clinically significant, how are we looking after them? Because remember, everything that we do in medicine, every single thing that we do in medicine carries potential risks. And so by the time we are giving, we're doing radical prostatectomies, we are giving brachytherapy for localized prostate disease, there are potential complications of those treatments, right? And somebody must be there to look after those complications as and when they occur. And so for sure that latent cancer is a problem. We're narrowing the gap in terms of how much of it we are treating, but it's still there, still a real concern.
Yeah, that's right. Yeah, I think Dr. Mathabe also says in the township streets there are lots of men who are doing welding, and I think they're doing welding not only in the township streets, everywhere in industry and in the home. But he says, can the cadmium found in this industry lead to an increase in CA prostate? Cadmium?
So I would have to admit that I am not sure on that one. I certainly am happy to look it up. What we do know is that various heavy metals, they are more likely to cause bladder cancer. So that would be the more likely risk would be for bladder cancer, but I certainly will look and see if it increases the risk of prostate cancer as well.
Yeah, maybe Dr. Mathabe can unmute himself and educate us on that. Tolakela, just make sure that we've unmuted everyone who would like to raise their hands. Please raise your hand before we come to you. Let's say, Dr. Maremong, are you able to unmute yourself now? Tolakela, can you assist? In the meantime, I think let's go to Dr. Leslie Ramia. Dr. Ramia says, given the likelihood of perineural spread in CA prostate, I think you've addressed partially this one. Is an MRI part of routine staging investigations, given the fact that delays in getting biopsies, etc., do exist and spread more likely? Can we hold, this is another, I think, is next question. Can we hold government accountable, or is it just a question of resource limitations? I suppose he's referring to the delay in getting biopsies and the results, especially maybe with NHLS compared to private laboratories, I'm not sure. But just your comments on the MRI scanning as a routine staging, you've already addressed that, I think, in your talk, and the fact that it's quite expensive, but also not all health facilities have got an MRI. But maybe your comments on that?
Yeah. So that's where we need to have our own balanced direction and perspective on how we do things. Absolutely, in a first world setting, they can probably afford, and I'm not even sure that they can afford to do an MRI on every single male. So we need to be balanced in our approach, and not everybody needs an MRI, not everybody needs a PSA. And prostate cancer, because it is a slow growing disease, we've got time. We've got time to study those PSA derivatives and PSA dynamics. So if all we have is a PSA, today and repeat a PSA in 4 months' time, we have not negatively impacted on the patient's prognosis. So we've certainly got room to do things and to optimize the investigative tools that are less expensive. In terms of holding government accountable, I mean, I think that's where the whole thing of evidence-based medicine comes in. And that's where the public health specialists definitely come in helping us determine how best to deploy our resources. I think it would be a poor use of government's money to be doing MRIs for possible prostate cancer on everybody, right? I think that is definitely not a balanced perspective on things. And so no, I would not be in support of that. But then we need to determine what is it that we support? What is it that we as clinicians think is reasonable, taking our local circumstances into account?
Great. I think Prof. Du Plessis is referring to the fact that in his chat, he says that the problem with the prostate is that men will only seek assistance when some of or other symptoms appear. most likely difficulty with urination. But it says also, it's something that you've also referred to, and especially because that the men are not health seeking, I think, as women are. Routine screening is not in the minds of men as like breast cancer and cervical screening is for women, and I think you've touched on that as well, which is very true as well. And Tolakele, are you there?
If I may,
Yes,
Dr.
I'm
Kenoshi,
here.
sorry,
Yeah.
Tolakele, while you
Please check.
sort out
Please
the
check on
next.
unmuting of people who'd like to raise their questions online. Make sure that you've unmuted everyone.
Yes.
Prof, you
Yes.
can comment on that, please.
Yes. So absolutely, Dr. Kenoshi, the health-seeking behavior of men is definitely a topic of interest. And I feel, though, that we cannot call men out. And it might be that at the end, we are absolutely pointing fingers at men and saying, you're terrible about your health. You don't look after yourself. You don't like to see doctors and all of that. But I feel that until we have adequate health resources for men, we cannot call them out for not accessing the very limited health resources. If you have young men, urethral stricture disease is a disease of young men at the peak of their prime in terms of vitality, fertility, ability to, earn an income, be gainfully employed, contribute to taxes. And these men, if they've got a urethral stricture and we put in a suprapubic catheter, and I now have to prioritize between, if they come for admission and I have to prioritize, I've got one theater that's not working, or whatever it is that my resources are even more constrained than they normally would be. If I have to determine who of these patients I'm admitting, I'm going to admit the cancer patient, right? Meaning that the young man at the peak of his vitality, fertility, whatever, does not get the attention that he needs, right? And so, and I then turn around and say, oh well, men don't seek help. But if when they seek help, we then do not have the resources to provide them with that care, I think we're really not in a position to be calling men out for the way in which they access care if the care is limited. So just a perspective.
Thank you very much, Prof. And Dr. Moromong, are you able to speak now? Unmute yourself. I think it's a problem. But there's Dr. Motlanthe with a hand. Dr. Motlanthe, you can go ahead, please. Dr. Motlanthe, you had your hand up. I think we seriously have a problem today, and for that, I apologize. I think maybe it's a technical one. And that's why I've been asking my technical team in the background to assist me, Tolaken. But let's go
Yes.
to, hello, Tolaken, you want to say something?
Doc, both doctors do have access and permission to unmute themselves, so they may go ahead.
Yeah, that's what I've been asking them. Maybe it's a problem of just knowing how to unmute themselves on the. I think if you hover your mouse or your cursor on the screen at the bottom, you'll see a mic with a red slash across it. Just click on it, and the slash will disappear, and you may speak. And that's how you unmute yourself on the system. But let's go to Dr. Munisi. Dr. Thabo Munisi says, I'm a physician in the military, Prof, and our patient population is well defined. I think we can screen, and I will need a research collaboration with Prof on prevalence and incidence in our setting. So maybe, how do you advise Dr. Munisi to contact you? I think we will send Dr. Munisi if we've got your contact details. You can just how can we do it? we can
there's two possible ways,
yes,
Dr.
please.
Kinoshi. So one is just my email address, kgomotso.mathabe@up.ac.za. But the other route, which might be easier, is on LinkedIn. That has proven to be quite a quick and easy way of access. So I've got a LinkedIn profile as
Okay.
well, and that would be an alternative route.
Great. I think that's for Dr. Mnisi and anyone who would like to contact you directly, Prof. Thank you very much for that. Quite a number of people have asking in the chat for a copy of your presentation, Prof. So our policy is on sharing the presentations is that it's only on consent of the presenter. And also we don't share necessarily with, I mean, today at the top of attendance, we had 549, 550, 549 attendees today. So we send to those who request, but you can just request us on webinars@clinix.co.za, webinars@clinix.co.za. I see one of us, Dr. Mathabe, I've got your details. Thank you. I've seen your message. We'll send it to you, Dr. Ledwaba. Remind me if I forget. But let's go to Dr. Surya Roeka. She says, thank you, Prof, for a very interesting talk, and to the Clinix group for providing us with an opportunity to learn such a wide area of our own fields, as Professor mentioned. It is certainly appreciated and makes for much more exciting learning opportunities. I think, Prof, you spoke about the scarcity of urologists compared to the population. I mean, it's scary figures of half a urologist for every 100,000 in population. How do you think we can make urology more attractive to young doctors who would like to specialize compared to other clinical disciplines? Do you think there's a way in which we can all assist in getting urology to be more popular as a clinical discipline?
So, Dr. Kinoshi, the problem is not popularity. People want to do urologists. We just have such a limited number of posts. There hasn't been an increase in the number of posts in forever. And so we are greatly limited by that. We had 2 medical officer posts that we interviewed for in February, 2 posts, and we had 262 applicants. And the GPG online system has really become quite sharp, because in the past, we would have people who got through who did not fit the criteria, right? We'd have people even outside of medicine who would end up on our list for shortlisting. But this time around, literally every single candidate fit the bill, right? 262 people who are interested in urology, and we only had 2 posts. So it is certainly not a matter of interest. There are people who have, chosen to go a different direction eventually, having waited 3, 4, 5 years for a post to open up, and they end up doing something different. So it is certainly not a matter of interest. That is not our problem. That is not our problem.
It's so sad, so sad. I've heard stories of one clinical department who received 800 applications for 3 registrar posts. I mean, it's amazing. But Dr. Mweketsi Mati says, in the absence of histology, how would you listen score the patient? And his second question is, will robotic surgery be available in the state sector? But maybe let's deal with the first one first. And listen scoring a patient in the absence of histology. Is that possible?
Yeah. So we can't. Gleason score is a histological feature, so we're unable to do that. What might be interesting is, can we correlate the worsening Gleason score to maybe some of the omics. So on liquid biopsy, do all prostate cancer cells that are floating around in the blood, do they all look the same? Or is it that we can say, no, these ones that react in this way are more likely to be from a higher Gleason score, a more aggressive condition, but certainly we cannot speak of Gleason in the absence of histology.
Yeah.
And maybe with that, sorry, Dr. Kinoshi, maybe with
okay.
that the number of people who are recorded on the National Cancer Registry as having cancer don't just speak to access to urology, right? It also speaks to access to pathology. Because if I don't have a pathologist who's going to look at the specimen, and we don't have pathologists that are sitting in far-flung, remote areas, is that then room for telemedicine, right? So could we have technicians who are in those areas, medical technicians and medical technologies who can process the biopsy done there and then have it be reviewed by somebody centrally? I know there's a lot of teleradiology work that is happening. So is there room for more pathology type of services? Because without them, my little piece of tissue that I've taken out means nothing if there's nobody to process it and then interpret it.
His second question was on robotic surgery in the public sector. Is there presence?
So there are definitely moves towards getting that to happen, but it is taking, longer than what we imagined. So there certainly are intentions to have that at Steve Biko. It is a joint effort between the university and the hospital. And certainly in the Western Cape, they've gotten it right, where they do have robots in state. So it's not an impossible thing to do. And I'm sure we'll get it right, but it does have to be a collaborative effort. And some of our challenges right now is that some of our infrastructure is a little bit old. And so we've had to sort of redivert our focus from maybe getting the new, fabulous toys to just making sure that what we have is fully functional. So I'm sure that this is just a matter of a delay and not that it's not going to happen.
I think robotic surgery, even in private sector, I think it's not every hospital that would have it. And I think that we need more of it. I think it's the expense that is more prohibitive than anything. I see that more and more questions popping up, and I think let's try to get them in the next 10 minutes, those that have not been answered. I think this one, you've referred to it a bit on the issue of PSA, but I think the question from Dr. Frida van Antwerpen is quite interesting on the same line. He says, I'm aware of a patient who had a Gleason 9 cancer without initial elevation of PSA. So I think the fact that we do our PSAs is no longer so reassuring. And he says, how sensible is PSA follow-up then in that case? And what alternative follow-ups can be recommended? I think you've touched on it a bit, especially about PSA derivatives. But you want to comment just briefly before we go to other questions? Please stop.
Yeah. Prof. So absolutely. I mean, for the undergraduates, for the registrars, they've got to tell me a different story. But for the undergraduates, for them, their answer to me when I ask what is a high PSA on which you must react, their answer is 4, right? But already up to 25% of cases or of patients with a PSA of 4 will have cancer, right? So there is never a PSA value at which your risk of having prostate cancer is 0. Right. So with a PSA of 1, you can have a prostate cancer. It is definitely rare. It is not the norm, but it can happen. And I think that patient makes it a little bit difficult in terms of the follow-up, because if we can't depend on the value of the PSA, so one would have to look maybe at those derivatives, the free PSA, might that make a difference? But this patient is going to be a difficult one. Maybe, I don't know if we would have had an MRI prior to that, and I'm not sure what treatment was given. So if the treatment was removal of the prostate, then it's different, because then there isn't a prostate to follow up on. But if it was radiation where the prostate is still in situ, we might be able to follow up on that. So yeah.
Okay. Yeah, I think this one is also interesting. It's from Dr. Sello Maloka, who says, considering the shortages of urologists and long waiting periods for biopsies that we referred to, what is your view on initiating anti-testosterone therapy, anti-testosterone treatment, based on patients according to age and PSA levels? I think you've answered the issue about PSA now, but testosterone treatment or anti-testosterone treatment, that's what
Yes.
is put it.
Yes. So anti-androgen therapy can be oral or injectables. And there was a study done a long time ago at in Stellenbosch. And what they did, they called it, I don't even remember what they called it. I think they called it a clinical biopsy. This was way back before all of the fancy new genomic stuff came through. But what they then did was to look at the PSA and the findings of digital rectal examination, and then the clinical assessment of the patient. And if based on those three, you could then say, looks like a duck, quacks like a duck, walks like a duck, that they would actually initiate anti-androgen or anti-testosterone therapy. So certainly one can make a case for it. It has to be well documented, and the reasons why you actually are unable to do a biopsy. But I think if you have all of those findings together, you can do. I would say for me, on a personal note, the caveat would be that the anti-androgen, anti-testosterone therapy that you are giving must be reversible. So either tablets or the injection. In such a patient, I would not do an orchidectomy, right? So I would not do surgical and permanent removal of testosterone in the absence of a biopsy. I think that's quite a big step, quite a bold step, and you'd probably find very few that would support that. But reversible in the form of tablets or injectables, and to see if there's an improvement in symptoms, I think is not an unreasonable action to take.
Great. I think Dr. Leslie Ramia has come back and says, what is the favored approach for biopsies, transrectal or transperineal? Transrectal or transperineal? And can lesions be missed even if ultrasound, if the procedure is ultrasound guided?
So absolutely. There's actually another question I want to go back to as well, Dr. Kinoshi. But the favored approach, so we tend to lean towards the European guidelines rather than the American guidelines. And so the European guidelines are now recommending transperineal approach. So we can do transrectal or transperineal. The concern over transrectal is the rate of infection, and we've not actually seen much, we've not had much problems with the rate of infection. We do it under antibiotic cover. And so that particular concern never really materialized in our setting. I don't know if, they're having antibiotic resistance or whatever in Europe. But so they are now recommending transperineal, that, either one. We are doing both here. And absolutely, lesions can still be missed, especially the anterior zone of the prostate, right? So even ultrasonography guided, you may still miss anterior lesions. Or it might be, so maybe the other thing might be that you're not necessarily missing the lesion. It might be visible on the ultrasound, but it might not be accessible, so that your prostate biopsy needle is unable to reach it just because it is in such a funny location. So that certainly is possible. And then the other point, Dr. Kinoshi, the other question that I wanted to go back on, sorry, was that the Gleason 9 prostate cancer with a low or practically undetectable PSA could also be if the cancer, so normally prostate cancer is adenocarcinoma, but if it has undergone neuroendocrine differentiation, then the PSA might not be high, and you've got significant disease. And neuroendocrine differentiation is funny in that it typically leads to soft tissue metastases. Prostate cancer preferentially goes to bone, and neuroendocrine will have the clinical picture of a low PSA with soft tissue metastases.
True. Yes. And Dr. Motlanthe, remember earlier on you referred to cadmium amongst the welders. He's come back. He couldn't unmute himself. Unfortunately, he wanted to say it orally, but he says he lists certain risk factors, of course, age that we know, family history, a high-fat diet, exposure to cadmium in cigarette smoke, alkaline batteries and the welding industry. I think that's where cadmium is prevalent, and it says maybe. And thank you for the education, Dr. Motlanthe. Obviously, we'll read that further together. Just screening through the other. I think we've come to the last of the questions. I think there are a lot of messages, Prof, on sharing of the presentation, but also on how amazing the lecture has been today. And I think maybe at this stage I should hand over to my colleague, the Chief Medical Officer within Clinix Health Group, Dr. Shinas. Dr. Burton Shinas, please unmute yourself and hand over to you to do the closing. Dr. Shinas.
We seem to have lost Dr. Shinas' talk.
Yes, okay, because I spoke to him earlier. He was in the meeting. You had made him a co-host. Dr. Shinas, I think you know him. He's shared. He wanted to make a few announcements and also to thank everyone. But if he fell off, he's the Chief Medical Officer in Clinix Health Group, and he's co-hosted the webinars with us. So most of you, the regulars, have seen it. But I would like to thank you again, Prof, for first of all for volunteering to do this. All speakers do it for free, although as Clinix we give a token of appreciation to our speakers and the amazing work that they do, the preparation, the serious preparation that they do for these webinars, I think is always amazing, acknowledged, and I think we learn a lot. I think there are very few people who would continue to learn, especially free of charge, in this manner. And we're greatly thankful for you for the time you took in preparing, but also spending the evening with us. I think to you, all of you, the over 500 attendees who are here, we thank you as well for being passionate about development, your professional development. I think we need it for the sake of our patients in the country, but also for teaching the young doctors and other professionals who are in our care. I know a lot of you work with colleagues. I think when you are empowered the way you get empowered on this platform, I think you will continue to empower others as well. We will continue, of course, with the webinars. We've got another one next week, Thursday as well. I see there's a hand from Patience Jot Malawa. Are you able to unmute yourself? You can go ahead.
Yes, thank you, Dr. Kinoshi. Thank you, Prof, for a presentation. I posted a question on the chat box there because I mean the climate in which we are at, it's that the time somebody seeks assistance and the time of diagnosis averages about 8 to 10 months. So I just wanted to find out what is the expected behavior of the CA prostate in that time, let's say over 3 months or over 6 months or over 9 months, so that is it predictable to say, okay, even if it takes that long to diagnose and to start treatment, so the behavior has not really accelerated that much. Thank you.
Thank you. I think Prof has touched on that, the progression of the disease, and especially from presentation coming already at metastatic stage. But Prof, you want to comment briefly before we close, please?
Yes, thank you, Dr. Kinoshi. So absolutely, that is a concern. It is less of a concern. The timeframes that you are speaking, 6 to 9 months, are less of a concern in prostate cancer than they would be in bladder cancer. So bladder cancer is quite aggressive and quite rapidly growing. So in bladder cancer, a delay of 3 months already has an impact on the prognosis, but in prostate cancer, less so. So we definitely want to see the patients early, right? But in prostate cancer, I mean, patients with prostate cancer, like we said, patients can live with prostate cancer and die of other things, and that not be the lethal event. But it's difficult to determine this, and it's difficult to predict. So I can't say it is okay, for us to wait 6 months, but we are in an environment where that is what is available, right? The number of people who can do biopsies, that's what we have. So that's what we have to make do with. So therefore, the solution is in trying to increase the number of people who are available to care for patients, that care can be provided quicker.
Great. Thank you very much, Prof. So I would also want to thank my team in the background who have been assisting, Tolakele and Sister Nesisa. Thank you very much for assisting. But thanks again, Prof, and thanks to everyone. See you next week. We will be sending invitations for next week in the next few days. So watch out and please register again. But still, we meet again next week, Thursday. All the best. Thank you. Dr. Sheenas, I think you had fallen out. We couldn't find you in there, but you wanted to make one or two announcements. Over to you. You can do the closure, please. Thank you.
I just wanted to say what was interesting about Professor Mathabe, for putting your hand up. We appreciate that you did that, for doing this presentation. So we mostly just want to say thank you for that. But I want to make a few comments about your background. I had a look and I see that you studied in Afrikaans at the University of Pretoria all that time ago. When I was at University of Pretoria, when the lectures were in English, the notes were in Afrikaans and vice versa, but I see you studied in Afrikaans. And then you went to the UK, but I understand that home, as you were speaking through the course of your presentation, home is key. You are rooted in South Africa, you grounded in South Africa, you love the South African people, and you want to spread this message of hope and care and self-learning and development on a regular basis and continuously. So you are proving testament to your message that you share. And what I also love about you is this element of gratitude that you have. And who goes back once they are a professor and they are renowned, recognized all over the world, and you go back and you say, I just want to say thank you to Magda Engelbrecht, who was your UP student administrator, who assisted you in getting into medical school, right? Then you thank Professor Hafaji, who took a chance and admitted you as the first woman to study urology at Wits. And then Dr. Evelyn Moshokoa, I think you said you saw in a magazine and eventually you got to meet. So that was really remarkable. And then lastly, I just wanted to say, I saw a question that was asked to you and posed to you once, which was, what advice would you offer young women or students aspiring to follow in your footsteps in academia or healthcare? And you said, follow your passion, make time for quiet time so that you can hear the whispers of your soul as it guides you. I love the quote that says, follow your dreams, they already know the way. Brilliant. And then you went on to say, I once met a young doctor who showed interest in urology. When I asked her why, she responded by saying, because there are so few women urologists. And then you said, that cannot be it. Urology is a fascinating and fun discipline, but there are for sure difficult times, and you must want to do it for its own sake. Follow the path that speaks to your passion. With those words, I'm just going to say thank you once more, and thank you to all our attendees. And may you all follow your passions. Thank you so much, Dr. Kinashi. Have a good night.